me up here. Sorry. No, you can stay. Don't go away. Don't go away. All I'm going to do is just thank Janelle and now invite up Beth Mathis, who's going to speak about the products and services available from the Council on Quality and Leadership. So please welcome Beth.
My name is Beth Mathis. I work for CQL, the Council on Quality and Leadership. We have worked in Canada in various iterations and lifetimes for a little while now. I'm here to talk today about our current accreditation process, person-centered excellence. You've seen two different types of presentations. You'll now see a third, and these are for good reason. They're different processes. Our vision and mission is, you can see here, I don't necessarily want to read it to you, but we are an international organization. We are based, our administration is based in the U.S., but we have staff based in Canada, in Ontario specifically, and in Ireland, Australia, and New Zealand as well. Our core competency is the helping organizations learn about how people define quality of life, learning then how to measure it and how to use that information in quality improvement. Probably the heart of all the work that we do is a set of measures called the personal outcome measures. And these, actually 2013 is the 20th anniversary of the introduction of the personal outcome measures. These are a list of 21 quality of life indicators that we learned about 20 years ago and have then studied extensively over the course of that 20 years through focus groups of people supported, professionals, family members. And these quality of life indicators are things that are important to all of us. They're things like being able to choose where and with whom you live, being able to choose where you work, being respected, having best possible health, being safe, nothing that would surprise you at all, having meaningful social roles on that list. When we use these personal outcome measures in all of our quality improvement strategies, including accreditation, we look at two things. We look at the outcomes for the person, how they define each of these individual outcomes, and we look then at the organizational supports for each of those outcomes. So we measure not only quality of life, but then quality of services. We can't measure the quality of services until we understand the definition. We also understand that all 21 quality of life indicators, the goal is not to have everything present for all people all of the time. The goal is to understand people's priorities. And if you had this list and looked at it, you would see that there are certain things that you would prioritize in your life. So we're looking at my focus and hoping that organizations have been able to use this process to understand the focus of each person that receives services. Once you have that information, the tool can be used in a number of ways, and there's no way I can talk about the complexity of the tool. It's elegantly simple and complex at the same time. But it can be used on a person-by-person basis to understand priorities and develop an individual plan that's focused on what's most important to the person. The data can then be aggregated to understand organizational strengths and opportunities, and used then in the aggregate to develop quality improvement strategies at the organizational level. I am missing one of my slides because it doesn't transfer sometimes from computer to computer. What I have here is data over almost 20 years from accredited organizations that includes a number of organizations in Canada over the years that rank orders the most frequently present to the least frequently present personal outcome measures. And I'll try to summarize that slide for you. This is not it. It's one before that. But what you would notice is, if you had it, is that the top 5 or 6 are things that make a lot of sense. We spend a lot of time in this field focusing on health and safety, rights, health and safety, continuity and security, privacy, those kinds of things, and rightly so. Those are foundational elements that we need to focus on. Those things are present 75% of the time or greater for people in this sample, which is almost 8,000 people. The things least often present, probably for 35% or less, are things, again, going to be no surprise to you, that we struggle with. Really, people choosing where and with whom they live, choosing where they work, having meaningful social roles in the community, and exercising their rights. This graph takes that data and adds sort of a piece of interesting information to it. What it means is, and I had to have somebody explain it to me several times because I'm not a statistician, but basically, these are the outcomes that are most and least predictive of lots of other outcomes being present in people's life. And interestingly enough, the things that we struggle with the most are actually the things that are most predictive of lots of other outcomes being present. The things that have the least impact on other outcomes are those things that are most present. So essentially what this slide says, and again, probably not a surprise to us in our field, but certainly a powerful piece of data, is that people can be safe and healthy and miserable. So, does that make sense? Okay. Now I'm going to talk a little bit about our accreditation, but I did want to lay the groundwork with talking about outcomes. We have 3 sets of measures. We do use the personal outcome measures. We also have a set of foundational organizational systems measures called the basic assurances. And we look at 2 things with those basic assurances. We look at systems, what sustains it over time, and practice, how they're actually being implemented. And the final set of measures we introduced in 2009 through an international series of both research-based and focus groups and other studies, and they're called the Person-Centered Excellence Indicators. We decided to develop those because after all of that other data that I just showed you, it was clear, although we know what to do, we haven't advanced our system. We haven't been able to bring true person-centeredness to scale. So we did this research to gather information about what are the practices that really consistently produce outcomes for people and result in a person-centered service system. So very quickly, I want to talk about the role of each of these measures. The basic assurances, as I said, is that foundational element. We look at your systems for health, data management, safety, HR, continuity and security, all of those, how you plan with people. And we look for your policy to some degree, but as more importantly, how that gets implemented and what the results are. These things are about accountability and transparency. We look for them to be both person-centered and system-linked, and by that we mean they're strong enough to be sustained over time so that it's not just dependent on good staff, but they're flexible enough to respond on a person-by-person basis. We think these are necessary and non-negotiable, but as the data with outcomes show, they are in and of themselves insufficient to produce quality of life. The person-centered excellence indicators, there are 34 of these indicators. I talked a little bit about how we developed those. And this process is about improving your systems for person-centeredness around things like governance and certainly quality and accountability, but also assessment and discovery. How do you learn about people and what's most important to them? Planning with people. How do you help people and organizations connect in their communities meaningfully? And then we talked about the personal outcome measures already to some degree, but what I would say is we don't come in and collect the data. We demonstrate to you the skill, and we hope that we ask that you then begin that process yourselves so that you build that competency. The accreditation process I want to describe as quickly as I can. How much time do I have, Sherry? Okay, good. The first step in the process of the actual accreditation, there's a lot of things that can happen ahead of time as you build up to this in terms of capacity building and learning. But the first step in the actual accreditation is what we call the request to engage. It's an application. But in this, you give us some information about your organization. You talk with us about what your vision and mission is, what your core values are, the services that you provide, and sort of some demographics around that, how you measure outcomes currently, and any sorts of targeted expectations you have from accreditation process. From that point, you may have started on this prior to submitting your request to engage, but there is a self-assessment around those basic assurances, and we're asking you to self-assess, as I mentioned before, on both system and practice. So pull together what your policy and procedure, training protocols, all those kinds of things are. Do a gap analysis. Where are you missing some things based on the basic assurances? And then also develop a plan and go out and validate the practice yourselves and give us some of that evidence. We use that information then in ongoing planning for the on-site visit. The first 2 days are focused on the assurances, and we look from your self-assessment for what are the things that we need to spend some more time with you on when we're visiting. So who do we need to visit with? What focus groups do we need to have? What kind of targeted interviews should we engage in to validate your practice there and to provide meaningful feedback for improvement? We will focus both on those things that you do seem to be doing very well as those things where you have identified opportunities and gaps, and anything that causes us to have a red flag based on the self-assessment and what we observe when we're on site. There are additional organization and preparation that we do together. There's a series of phone calls to finalize the schedule on site and to plan for the person-centered excellence portion of the accreditation visit, which is the final part of that. And that is about, well, I'll talk about that. But the on-site visit, we do the assurances validation first. The tail end of the visit is the person-centered excellence portion. We ask you to assemble a group of stakeholders representative of your organization, including people supported, families, direct support professionals, board members, leadership, and community representatives and funders if you can get them there. That group generally meets for a day to a day and a half and actually does a real-time self-assessment of how person-centered you are. They rate your organization, they identify priorities, they develop recommendations, and feed that back to the leadership for the final accreditation plan. One thing I should say about our accreditation is that it is generally, unless you're a very large organization, a team of 2 people, one of whom is a self-advocate, somebody who receives services, and we do employ somebody here in Canada, a self-advocate who would be that member on a team. That person's responsibility, in addition to some other things, but is to prepare the people receiving services of the organization. They're going to be part of plan development so that their voice is truly meaningful and heard in the process and it doesn't become a token. There is then, once you're accredited, you will be implementing your plan. There will be coaching. There's 2 checkpoints along the way. It's a 4-year cycle. There's an informal teleconference at 9 months just to make sure everything's okay, and then data reporting and a more formal follow-up at 18 months that can be on-site or off-site depending on your progress with the plan. Accreditation criteria, that the basic assurances are substantially in place with no red flags, and we do have a listing of red flag indicators that we look at every organization. The implementation of your person-centered excellence plan, and ongoing use of the personal outcome measures in your quality systems. That is that. Did I make it? Yay.